The exam is artificial. The exam is not testing what it actually professes to test, which is um, uh, testing you as a safe level at the level of an Australian trained intern, I believe is what they say.
Hmm.
Um, it doesn't do that. Here's what you have to say. For physical exams, this is what you have to do. If you don't do it, they will not pass you. And it might be a little thing as in a physical exam for respiratory illness to start with the fingernails and then work your way up. Because when have you last done that in ED? So, years ago, if
Hmm.
at all.
Hmm.
So then in the exam, it was the most surreal experience I've ever had in my life. It's an online exam. So I was sitting in a hotel room, and essentially you have the screen much like we have it right now. So you have where you would be the invigilator. You can see this guy every now and again. You can see yourself. And at the time when the exam is on, so you moved from the waiting lounge where everybody else is as well on the screen into your exam space. At that point in time, there's two more little icons coming up. One is the examiner who's permanently blacked out. They
Hmm.
don't have their video on, they don't have sound on. You don't see them. You just know they're there. And the patient and the simulated patient. And the simulated patient is doing this from home, right? So they're sitting in their lounge or in their bedroom or whatever. It's hilarious at times. Um, and then you do your station. The left side of my screen, where I now have your AMC Clinical Course thing, that's where the stem is, and the stem stays there for you to sort of peruse. You don't have any clock on the screen. You don't have any timing device whatsoever. They give you a either 6 minute warning or a 2 minute warning. They will tell you what
At
sort
the
of
end of your
warnings to give
scenario,
you.
just prior to your
The end of
scenario.
the end of the scenario reading time, which is 2 minutes, they will tell you we are now moving you into the exam,
Yeah.
and that's when the patient comes up. But they also tell you prior, okay, so for this station you will get a 6 minute warning. And so after 6 minutes, they say this is your 6 minute warning, and you kind of click into gear and you go, okay, I need to, do X, Y, Z of my tasks. Um, Essentially, they said you're not allowed to have a stopwatch or anything really,
Mhm.
but you must have your mobile phone next to your computer in case your computer drops out. AMC needs to be able to call you immediately. But to give you an example of what the level of an Australian trained intern in the AMC exam means, take this station. Your patient is a 62-year-old gentleman who has been seen by you in your GP practice. You're an intern in GP. In that GP practice, you've seen the patient 3 weeks earlier and diagnosed him with a UTI. You referred him to a urologist. Why on earth would you do that? But okay, you referred him to a urologist. The urologist did a PI exam. In brackets, you should have really done that in your practice. Okay. And found the prostate to be not only enlarged but also suspicious. The urologist furthermore did a PSA test, which was sky high. He then did a TRUS biopsy and found a prostate carcinoma, Gleason 7, they give you that,
Wow.
Gleason 7, um, with an MRI of the pelvis showing that it hasn't breached margins. And he then sends you back to your practice. The patient gets sent back to you for pre-operative workout or workup. So that's your STEM. Talk to the patient about his diagnosis and answer all relevant questions. The patient appears, and the patient was an amazing actor. So I can tell you, lucky I
You're
did
a urologist by
urology.
background. Yes.
Exactly. So I knew I knew what a Gleason 7 is, and I wasn't worried about it. But so Gleason score is made up of two numbers, number A and number B, and it's basically a combination that tells you how aggressive that cancerous lesion is. A Gleason 7 is something you see extremely often,
Hmm.
and it's sort of in the sweet middle field. They're
Hmm.
not very aggressive, but they're not super benign either.
Hmm.
His is in the within the capsule, so it hasn't breached the capsule. This cancer is happily operated, and once you take the prostate out and do a little bit of radiation, Bob's your uncle, you're done.
Okay.
So I knew that, but yeah. Anyway, so the patient comes on, and the first thing he says, "Doc, doc, I've got cancer." I'm going, "Yeah, you do." And then he says, "What do we do about this cancer? What do we do about this cancer? Doc, what do we do?" I said,
Hmm.
"Well, I'm
Hmm.
not the urologist. He should have really told you that, but I can tell you a little bit, blah, blah, blah."
Hmm.
So you counsel him, as IMC puts that. You counsel him about his condition. And then he comes back to you and he goes, "But I still want to have sex."
Hmm.
Well, how do you answer that?
Hmm.
If you're an
Hmm.
intern in GP, he's referring to nerve sparing in the
Oh, the
operation.
nerve damage during the operation in which we cannot get the
Hmm.
erectile function. Okay.
Exactly. That's what he's referring to. And you have to counsel him about the fact that these days surgery is actually uh, fairly safe with robotic surgery achieving nerve sparing rates in the high 90s,
Hmm.
90%, that is. So, yes, you most likely will have erectile function. If not, we can do something about this with injections, devices, la di la di la. And then the next thing is, but I don't want to dribble the whole time,
Hmm.
i.e., he's referring to incontinence.
That's right.
So you need to counsel him about that.
Hmm.
And you have to do all this within 8 minutes, and you're an intern.
Hmm.
Sorry,
Hmm.
this is
Hmm.
not realistic.
Hmm. Hmm. Hmm.
I mean, I passed this, and I passed it with a 6. Um, I don't know what else I could have done to achieve a 7 in that station, but apparently there's something else.
But I think Andy goes on showing that there is more to this exam than obviously just the diagnosis. It's
That
about
is
taking
correct.
his concerns about, as you said,
Yeah.
the nerve damage, the erectile dysfunction. And I always teach my candidates that you may have a command of a subject and you may not have a command. But as an intern, what would you do in real life? You can say, okay, fine, look, this is the situation. You've got a cancer. It needs to be resected or operated by a urologist. In terms of your specific query, I know this is an issue. This is a real issue. But in terms of realistic numbers and risk factors in your particular case, urologist would be the best person to answer you this question.
Yeah. Yeah.
Number two, yes, I take your concerns on board in terms of dribbling. These are the options. But again, urologists would be able to give you more updated version of the other options. So I think this, from that perspective, it's a salvageable.
Oh, yeah,
And
yeah, yeah. No, no. You don't have to have all that knowledge to pass this station.
that's right.
You will have to have a basic understanding. And I think that the crux in this station is you have to actually have an understanding of the Australian health system, which most of the course candidates
IMGs
obviously don't
don't
do.
have. Yeah.
And that was the one thing that always kept me sane in the journey to this exam. Because I kept saying to myself, look, I've worked in this system for the past, I don't know, 13, 14 years. I don't know how long I've been here now. Um, there is not many people who know this system better than me. And I probably know it better than some of the examiners because I'm simply older than
Yes.
them. So, you know, that's fine. I can do this. But going online with my tutor, I got shown every day that there is the little fine details that the AMC wants you to say and do that you don't do in your daily practice. And to this day, I mean, they want you to auscultate a chest in 9 places. I will challenge you, if you see a patient in ED, how many places on the chest do you auscultate? not 9. I can tell you right now.
Yeah.
But
I
yeah,
remember,
so
Andy, that we were making this conversation that we need to do the talk and we need to do the walk.
yeah.
And only when you do that, and I'm glad that you're the person. And look, let's move on. I'm first of all, I'm very thankful that you're joining us as a faculty. I
Oh, I'm
always
grateful you
have
have me.
had a firm belief in you with your conversation and your experience. I think that's just a perfect balance. And you've passed the AMC exam just recently, so you're up to date and breast. So what we are doing in our course, this is the second installment, obviously. I'll tell
Hmm.
you about our introduction. Let me know if you can always interrupt me and ask me questions. So this is our faculty. Sandia.
Oh,
We
yeah.
work. Yes, yes. Qasim is another Faisal.
Uh-huh.
Khadeja is his wife, and then it's you, my friend. And
Perfect.
so it's a good mix up of faculty. We've got a timetable which I'll show you via the link. We have got a course communication WhatsApp and email group, so all the
Hmm.
faculty and participants are there. So the learning is obviously confined to the classes that we're doing every week on a daily basis, 3 days a week, but it also overflows into our WhatsApp group so they can communicate amongst each other in terms of a challenging scenario or recall or what have you. And I find this very intuitive because I think it gives them another avenue of answering up a query with the whole group of people. Now, the next course is big. It's
Hmm.
completely booked out. We got a lot of
Hmm.
participants. So I think I'm very excited. Compared to the first course, we got twice the numbers. So it's excellent. So based on the feedback that we have received from the first course, is that we need to have a framework. And this
Hmm.
is the crux of our course. Some of the things that you've just alluded to are built around that structure of framework. So this goes on showing that you're a person with an extensive knowledge and experience, being an
Hmm.
emergency physician, working in the system, which obviously gives you that unfair advantage of a huge magnitude. But then again, you cannot execute to an easy pass. You need to have a bare pass with that armament of resources. So that frameworking, as you just said, how can we polish amongst ourselves as a faculty to be able to teach that frameworking to our candidates for them to able to pass this exam? And I agree with you, it is an easy exam, which is in a sheep's clothing, like it's a wolf in a sheep's clothing kind of.
It is.
So it's
It is.
it is an easy exam, but the way they assess that exams are you've got to do their own way of doing things.
Yeah.
So I think one of the feedback was that we need to have framework, we need to have
Hmm.
notes, and people really, the candidates from the last course really liked our feedbacks, framework structure,
Hmm.
like how we intro, how we do the body, how we conclude our station in terms of time. And we were pushing them from the time perspective. So we were actually getting them to finish a scenario at 7 minutes. So
Hmm.
they were
Hmm.
really had that rapidity of thinking. And
Yeah.
then with a certain sentences and terminologies, building up these repo and empathy. So obviously that goes on showing that you're not just a robot sitting there to pass the scenario. You're there as a human being, as a
Yeah.
doctor, to build up that bridge of communication with your empathy. So what I'm going to do, I'm going to provide them with notes. So they will get a readout before the session.
Mhm.
I'll be providing that readouts. They will do a session in terms of role playing. So when you're doing that as a faculty, you're observing them as a faculty role playing. One is role playing and one is doing the scenario. So they head on, head to head,
Yeah.
and you're just keeping the time. You're just taking
Yeah.
your notes.
Yeah.
At the end, bell goes up. You said, your time's up. This is your feedback,
Yeah.
and then you flavor it in with your personal favor as a faculty, that what do you think went wrong, what do you think went good, and what are the critical errors.
Yeah.
We will be video recording all sessions, so uh, I would have the video file, so then they have gotten access to that video file, because obviously some of your feedback would be valuable, and if they've not been able to see or and they want to refer back to that feedback, they will have an access to those videos. And some of our participants, they have got morning commitments, they may
Yeah.
not be able to attend all sessions, so they'll always have a backup of that video recording. All right. And let's talk about the sessions. So I'll get them the material before the session. They will
Mhm.
do scenarios, 8 clinical scenarios in terms of faculty role players and participant role players. So they will role play amongst each other with other faculty members and with other participants. So it's a very robust, very entangled, very networked kind of approach.
Mhm.
But 8 participants will be working in session one and 8 participants will be session two. So we'll be alternating. So 8 participants who've been able to role play in your session would not be able to role play in my sessions, would be the different 8 participants. So we'll give a very diverse sort of experience. So they get the both end of the picture.
Mhm.
They'll get 2 minutes of reading time and then 7 to 8 minutes of performance. So I think we will start with 8 minutes of performance in initial, but then we'll push them closer to the exam dates to about 7 minutes, 7 minutes performance. Um, and then you'll do a 10 minutes of calculated feedback time, starting with the critical errors. These are the critical errors which were there. You did
Yeah.
not say them, you're not passed. So we need
Yeah.
to really push them. This is not a lovey-dovey course. This is something that we are taking very seriously with strict time management, with strict critical errors. If you're not doing that, you're not going to pass that. Because
Yeah.
if we are strict here, they will have a lot better chance of passing the real scenario.
Yeah.
Um, Last 20 minutes of your session, of 3-hour session, you can open the forum and say, let's do Q&As. If there's any particular Q&A in your mind, if there's any particular issue in your mind, communication aspect or clinical knowledge aspect, let's just open the podium to the rest of the participants and discuss about it. If you've got time, that would be good.
Mhm.
Now,
Mhm.
I'll show you our slide structure of the course. So this is our approach basically. So standard approach, all the faculty will be doing exactly that. So you, me, Qasim, Sandia, Khadeja will all be following this structure. So we are standardized across the board. So for every scenario, the slide one will be course focused, our emergency course focus approach slide, which I'll show you. Slide two will be reading the scenario slide that you get presented. Then slide four is going to be what you understand from that scenario. What is that scenario all about?
Mhm.
And what differentials can you come up with? So your
Mhm.
map layout, how you're going to spend the 7 or 8 minutes of your scenario time, that's the slide four.
Mhm.
Then slide five is doing the actual scenario. So how will you approach and do and deliver? And then slide six would be the feedback time with you in terms of 10 minutes. And then we'll use the next couple of slides or few slides to do a particular tutoring
Mhm.
around that topic. It might be a septic arthritis, it might be an pneumonia, it might be a breaking bad news, whatever you have to offer them extra based on your knowledge and your extensive clinical experience, that will be a topic tutoring, but it's all be fit in that feedback time.
Okay.
Now, any questions at this end?
No, not so far. So the what I find important, having just done it, the slide four, 5 key points and 3 differentials. That's something I would sort of harp on about because that's what they want you to do. They want you to literally exclude every single differential in the way that you say to the patient, okay, you could have pneumonia, but we are discounting that based on X, Y, Z. It could also be bronchiolitis, but I'm discounting that on X, Y, Z. So that's
Exactly.
the, you know,
And
that's
Andy,
really important.
that's our bread and butter as emergency physician,
Yeah,
right? We do that.
but
So
but
I'll
the
show you
issue is
this. Yeah,
the issue what we do, Matt, to sorry to interrupt, is
that's okay.
we do that up here. You do that standing by the patient's bedside, looking at the patient, looking at the monitor, looking at your
Mm,
results. In your head, you've already run through all this, and you arrive with a diagnosis, and you go, "Yeah, he's got pneumonia. Bye." Because we are time pressed. That's what we do. In this exam, you need to talk it out, and that's
yeah.
the difficulty
Yeah.
for, especially for more senior people who maybe in their own country were quite senior. That's why they all fail it because they all have the state of mind they see, they assess, they arrive at a diagnosis, but they don't talk it out.
No,
Anyway,
you
keep going.
have said a beautiful thing that the more senior you become, you develop your own ways. 2 minutes is positively utilized for the course, for the scenario to be done. The
Yeah.
other thing is, Andy, scenario needs to reflect the story. That's what I'm saying. We need to help them lead to the diagnosis
Yeah.
and management, and obviously, peppered with empathy and communication skills. So, and that can only be done if your scenario is well written. Um, Role player notes. So when you're writing your scenario, you write role player notes. Like, you write the positive findings only, like what are the positive
Yeah.
presenting complaints. Negative could be anything, and you can say that no, there's no shortness of breath, no, there's no leg swelling,
Yeah.
no, there's no overseas travel. That's easy. No's are easy. The positive, which the role player, which I'll be sending out to the candidate, you've given me the positive, I'll send them out. um, Now, need to add images. So obviously you've seen in your AMC scenario, if they want you to make a decision based on image, so have an image incorporated in your scenario, like an X-ray, clinical picture of a rash, of a deformity, of an injury, of a wound, so that it gives more realistic way, just like the real exam. And at the end of the scenario, as you just said, diagnosis and three different diagnoses. That's what we're getting them to come to. And investigations at bedside, that's, I'm using that emergency framework. Remember that we used to think about investigations at bedside, labs, radiology, and special tests. So if we, Andy, if we, and correct me if I'm wrong, if we get them to think about this investigation structure as bedside, labs, radiology, and special tests, and management as general, specific, and disposition, the timing efficiency could be very good. They
Yeah.
can not
No, I
miss
agree.
anything, isn't it? Okay.
Yeah,
I'm glad
I
that you're
agree.
on board with that.
I agree. No, no, I agree. That's
So, in terms of when you're giving the feedback, this is the structure that we're following. Feedback slide, this is exact slide. So, introduction, comfort, consent, stability. Did you do that? Oh, you missed the consent. You missed the comfort. I'm not going to pass you. So, we are strict. We want them to incorporate that learning from day one. Was
mhm.
empathy there? Did you check if the patient is crying? You offered the tissue paper. If the patient is distressed, you said that, is there someone else here with you who would like to, do you want me to call a social worker? Was it there? Because if it's not there, we're not going to give you a tick on that. Did they complete each task? It's not about knowing the content in detail. You may have an extensive knowledge about Gleason 7, but it's not about Gleason 7, as you just said. It's about answering the question of giving him options, empowering the patient. Did you do the task of history taking, breaking the bad news,
Yeah.
giving the management plan? So if you're not doing the task, I'm not going to pass you. And please, please make sure when they're ending, summarize, Q&A, offer them the information sheet that, look, you may have some more questions. This is the reading material. And when you're sending them home, if you do, from your clinic or from the emergency department, these are the danger signs. If you get
Yeah.
fever, if
Safety
you,
net.
yeah, safety net, as you just said, that it's all about
Yeah.
differential and safety net. So
Yeah.
that's all there is to it. It's very simple, very quick, very uh, to the point. So
Mm.
our candidates are not lost; they're actually focused on this framework, and they can pass. So I've got this scenario as a limping child scenario. I'll give you an example how we're going to do that. So this is our focused approach. So this is the first slide that you show in your course. So we encourage our candidates to read the task first. The task could be 2 statements or 3 statements, like read the task, then read the question related to the task, and outside or before starting the station in that 2 minutes, make a diagnosis, make a differential, and plan those tasks, how you're
Yeah.
going to deliver them. So, as I said, introduction, comfort, consent, stability, ICCS, repo, explain, plan, framework. Don't miss anything in terms of history, examination, investigation. If the task is that, don't miss anything if the task is diagnosis and differential, task number 2. Don't miss anything in terms of management, which is general, specific, and disposition, follow up advice and counseling. And at the end, please don't miss squid, which is summary, Q&A, information sheet, and danger signs.
I like squid.
You like it?
I like squid.
So, like, this is the scenario. So this is how we're going to do. So this is uh, we read the task first in the first 2 minutes. Take a focus history and ask for the relevant examination. That's my task number 1, which I must do. Give the diagnosis and what investigation would you do in this particular patient. Okay, so there's a patient in which I have to diagnose the condition, and plan the investigations. And
Mhm.
explain Mrs. Jackie Roberts about your management plan. So now you're switched on. There's a person in the scenario called Jackie Roberts where I have to explain the management plan. So I already know about my task. It's about examination, focused history and examination. It's about diagnosis and planning the investigation and explaining Jackie Roberts about the management plan. So what is the scenario? 6-year-old boy Jaden has been brought into general practice by his mother. Jaden has been complaining of right hip pain for past 3 days, and in the last 2 days, he started to limp. There is no history of trauma and fevers, but Jaden did have some mild sore throat last week. Mrs. Roberts is quite concerned about Jaden's mobility. You've got 2 minutes. You're already thinking about the diagnosis because that's what we do as doctors. We got,
Yeah.
oh, it could be septic arthritis, could be transient synovitis, it could be Perthes disease, it could be SUFI, it could be musculoskeletal, it could be trauma, it could be NAI. So all of that. But what is the most rational thing? Oh, it'll come through the history when we are role playing. I'll sieve out all that unnecessary information and the more focused information will come. So I need to take the history. That's my
Yeah.
cue number one. I'll be able to. So my presumption right now is already erring towards the well-looking child, 3 days not being able to walk. It's probably transient synovitis of the vertebral hip. That's my main history, which is going to focus. Relevant examination, I'm going to do that. And diagnosis investigation, which I'm going to plan. So what we do next, they do the scenario, but they're thinking about the key points. So key points is a 6-year-old boy, 3 days of right hip pain, 2 days he started to limp, mild sore throat, and quite concerned mother. So these are the key points which I must focus on. So my diagnosis of irritable hip and 3 differentials of septic arthritis, or Perthes disease, and you know, um, uh, and the other differential could be musculoskeletal injury or NAI. But my concerns are that I need to highlight these sting issues well. You asked me a question. Yeah,
I would add one to that, Matt.
yeah, yeah, yeah.
No known history of trauma.
Perfect.
So that
They're super focused.
in your SIF, you already go, this can't be NAI. He hasn't fallen over. These two are out.
Completely agree. I think the original scenario that I wrote, it did mention no history of
Yeah.
trauma. So then the candidates will do the scenario in terms of reading the task first, doing the scenario. So they're doing the scenario in 8 minutes now.
Mhm.
All right. You make your notes in terms of feedbacks, and then we go and give them the feedback. This
Mm.
is the feedback. Now you will have the feedback written in
Mhm.
your
Mhm.
notes that this is what they must say, do, or show it to me.
Yeah.
And this feedback is based exactly on this framework. And if they're missing out on anything, you're not going to pass them.
Yeah.
Because once this critical error, plus the other thing which they must do is this approach. And then you talk them about, okay, fine. The diagnosis was trypanosynovitis, most common cause of acute pain, 3 to 10. This is the clinical presentation, often preceded by upper respiratory infection. Yes, he did have an upper respiratory infection. And managed with supportive with NSAIDs. But in that time, you're also talking to the mother, explaining that, look, he's not got fever. He's systemically looking well. I don't think it's a septic arthritis. How about we do some blood tests and make sure they're all okay?
Yeah.
How about we get an ultrasound, make sure that there is nothing bad about, or get an x-ray done, make sure there's no features of osteomyelitis. So I think it is very simple if we structure it well, but it can get out of hand if we don't structure it well.
Yeah.
Any
Correct.
question from that point of view?
No, that's pretty straightforward. That's fine.
All right. And then we've got some slides about hip pain in
Mhm.
children and then limping child red flags. So sudden onset fracture or NNI, unwell looking child, um, would be septic arthritis and osteomyelitis. These are all the differential pain for more than 7 days. You're thinking of malignancy or hematologic issues.
Yeah.
Nocturnal or constant pain obviously is also concerning about mitotic or malignant issues, and fever, weight loss obviously.
Yeah.
And that's about it really. Anything what you think is uh, apart from the standard deviation?
No, no, that's pretty straightforward. That's covers it all. It's it's minor things that I would add, or yeah, basically say, look, the thing that I find most important is for the candidates to understand that in that exam, it's an artificial environment. You need to play that environment. you need to understand that you can play that environment. If you have the structure that you've just outlined, if you follow that structure, you can literally do any station and you will pass it.
Funny that you said that, Andy. There was a candidate in our previous session who was just so stuck to the structure, and she was able to salvage 80% of the scenario with
Yeah,
that frameworking approach. And
yeah,
I would struggle to fail her based on
yeah,
the critical errors because you just have not given me any chance. You've got an empathy, you've got an introduction, you've elevated all my concerns that even if it's within not my clinical expertise or jurisdiction, I've escalated that I will get you the right information and management
yeah,
from a specialist, and I've made a very safe plan for you.
yeah.
You're
That
absolutely right.
that's what it's all about. Now, the other thing is obviously clinical examination. They're quite particular about uh, the steps they want you to take there. So if you have clinical examination in your scenario, that's the thing that we obviously have to teach them, I guess. And I'm pretty sure you've got your slides there as well. Um,
So clinical
and you just
examination, we're doing 4 days extensively
Mhm.
for clinical. It's all
Good,
scenario-based learning.
good.
Um, what I have been able to understand about the clinical examination, it's a clinical examination which is focused towards the pathology. So say for instance, if they are like let's just take the example, if it's a focus examination towards this child with the right-sided hip pain, they would want you to examine the right side in terms of inspection, palpation, movement of the right leg, which is the symptomatic side, plus the left leg, which is the
Yes,
non-symptomatic side, lower back. Make sure all of that's fine. Check the gait. Make sure the lymph
yeah,
nodes are in line. So all that in a very structured way. So we have
yes,
dedicated a complete 4 days for all the
good.
cardiovascular, respiratory, rash, and some clinical conundrums-led examination. So the patient who's come in with facial nerve palsy, the patient who's come in with oculomotor nerve palsy, or the patient who's come in with this shingles rash. So not only you're examining the rash, but you're giving me the diagnosis and management.
Yeah. So every physical exam has, as you said, the key points, and you need to drill them in so that you don't miss those little key points, and they are little. So, for example, if they want you to examine um, the chest, they would want you to say that you palpate for Virchow's lymph node, which is up here, and they would need you to say that it points towards gastric malignancy. Whether that is in your scenario or not is in that moment irrelevant because they want you to say, so we are going then from, my retroauricular lymph nodes to my cervical lymph nodes, anterior posterior chain. I would then palpate for lymph nodes above the clavicle on the right side for Virchow's lymph node, which can pertain to gastric cancer, and then you go on. If you've set that little tick, it's a tick in the box, and they will just go on. These guys aren't. They are literally ticking a box.
Oh
If you
yeah,
said it, you
absolutely,
get the tick. But you need to say these little things because
mm,
otherwise you lose that point, you won't pass.
absolutely.
So
You remind
yeah,
me of a same kind of structure when I was doing my AMC. Obviously, it was all demonstrating and speaking at the same time, and I did the lab prior to that, and there was an issue that how do you approach that? Do you do the examination quietly and the examiner is observing, or you do it speaking? So I said, no, you do it speaking.
yeah, you need to do it speaking.
And
And in the
that's what I
online,
did. That's what I did in my fellowship exam as well. I was examining, speaking. And
yeah,
that just gave me this very constant self feedback. Oh,
yeah,
so I did something which I'm teaching now is diagnosis list feeding, is exactly which you said to me that look for the supraclavicular nodes. I'm examining from the gastric cancer point of view. There's no supraclavicular lymph node to make me think about the gastric malignancy in a
yeah,
patient who's come in with abdominal pain or epigastric pain.
yeah,
So
bang, done. Yeah, and I would say that in every clinical exam, there is one little tiny bit that you need to say, and they might not even listen to the rest of your examination because you've said it, you tick that box, goodbye.
mm,
But the online exam, if they take an online exam, you are literally just talking. You're not even demonstrating. You might be able to demonstrate on yourself, but you've got to be careful when you do that because it's obviously a mirror image. So if you talk
Yeah.
about the left side and you show them the right side, you're out. It's, so that it's fraught with danger, but you have to essentially just talk through. And the way I did that in the exam, I basically had my eyes sort of half closed
Mm,
while I was doing it because I was literally in my mind going through it. And I said that to the med students. I said, you will see that I'm looking a little bit funny while I do that, but I just imagine going through on a real patient, which I don't have in front of me at the moment. Done.
perfect.
Be
Yeah.
yourself. The one thing I learned in this exam is be yourself. After the first two stations where I had no frigging idea what they wanted from me because they showed me a rash and I'm going, thanks, I'm out. This is it. Thanks, guys. But then I thought, stuff this. I'll just be myself. I
Exactly.
know that I can talk, and I know my frameworks, and I know my, my clinical stuff. So just be yourself, and I was, and I think that saved my exam. So I would say to every candidate we'll encounter, I would say, be yourself. Don't try to play. I know it says role play.
Mm,
Don't play. Don't be an actor. Be yourself. You are all doctors. You've all gone through med school.
mm,
So, you know, you know how to interact with a patient because some of you guys, like old dogs like me, have been doing this for 15 years. Others have been doing it for, say, 2 or 3 years, but you've been doing it for years. Be yourself. Be a doctor.
excellent. Excellent. No, I think that's a very good piece of advice. So, look, I think we've got a very exciting course. We've got good numbers,
Mm,
and I think we can use that hub, that community, to
yeah.
learn amongst each other. And if we stick to the plan over next 8 weeks, so our course is 8 weeks, three
Hmm.
sessions per week. Each session is 3 hours. And we've got very good faculty. We've got you, we've got Sandia, we've got Qasim, we've got Khadeja. I'm in there as well. So I think it shows a very diverse input from a number of different people. And I think that shows the variety of learning from 5 different sources. And
Yeah.
the good thing, we're all working in the Australian health system. So
Yeah.
that gives us an edge about incorporating some of the things which are only available in the Australian health system, which you can incorporate in your answer. Oh, I've got an access to this clinic. I've got an access to this follow-up. This is how we do in our routine. Because I think the exam is also a bit tricky from the point of view. They're assessing you, as you said, at an intern level who has not yet worked in the Australian system, but at the same time, they expect you to know about the Australian system. That look, how would you follow up this patient with Gleason
Yeah.
7 with the urologist? How do you go
Yeah.
make him an appointment in urology clinic? What is the contingency advice coming back if he goes into retention or has got a
Yeah.
problem? Yeah, so I think that is unique. That there is an expectation which is not obviously stated, but is an expectation from you.
Yeah. Yeah.
So I think our role is not only to teach them that particular way of passing the exam, but also to teach them how it's done routinely day in, day out, every day in Australia.
Yeah.
And
Yeah.
that is something unique that we're offering them. So yeah, pretty excited about it. Any further input, Dr. Andy?
It's fine, my friend. That's fine.
I am
I'm.
so glad to have you on board, honestly. I'm
Well,
so
thank you for
glad.
having me. It's great. Um,
I'll
in
show you
terms
the
of,
timetable now,
yeah,
and we'll just go through the timetable. And I think
yeah,
I've recorded. The reason I recorded because I wanted your input. You've recently passed the exam. You're a very senior physician. You come on board on the faculty, and I wanted to just get those pearls of wisdom from you and be able to talk. And so I'll stop the recording here. Then I'll show you the slides. Is that okay?
no problem, buddy. Yeah, sure.
All right. So